Good morning, everyone. How are you doing out there? October 12th, we're going to go ahead and call the audit review to order. First order of business is STEMI report by Brenda Williams. She's going to take care of that for us. Here you go, Brenda.
Good morning. Again, I'm Brenda Williams. I am the manager of pre and post cath lab and inpatient telemetry, and again, the chest pain coordinator. Tag on it. Yeah. So we'll get started. This is EMS REN from back in August. Started at 13:31. They were dispatched for what they were told, just an unconscious male. By 13:38, they arrived to find an 80-year-old male sitting in the living room chair, alert and oriented. He was cool, clammy, pale skin. No distress when speaking. Just got home from the store, felt sick, and went to the bathroom to vomit and passed out on the floor for approximately 5 minutes for a family. Denied chest pain. States chest just feels really heavy with no radiation of pain. Denied breathing difficulties, but has slight burning sensation upon inspiration. He felt like passing out when stood up to ambulate to the cart, so they got a chair, and the chair was utilized to transport him to the cart. He denied strenuous activities during the day and any previous heart problems, except for the history of hypertension and diabetes. He was a former smoker for 37 years, but he quit 30 years ago. By 13:43, they got a 20 gauge in his left AC. Put normal saline at 4 drips is the way they posted it. I thought that was fine. 4 drips per minute administered. Informs EMTs that he is allergic to aspirin, so they did not give it. By 13:45, his blood pressure was 120/62, a heart rate of 61, respirations of 16, 96% on room air. His blood sugar was 120, which was normal for him, is what he told EMS. And he was in sinus rhythm. 13:46, they gave him a nitro spray, 0.4 milligrams, sublingual, no change. 13:51, they got his blood pressure again, 122/80, heart rate of 46. Respirations 21, 98% on room air. Now the 12 lead was showing elevation in lead 1 and AVR with depression in leads 2, 3, AVL, AVF, and V1 through 5. But 13:59, they arrived to Union ED. 14:01, another EKG was obtained. By 14:16, the cardiologist agrees to take the patient to the cardiac cath lab. He arrived in the procedure room at 14:46. By 15:10, they ended up getting an IABP or intra-aortic balloon pump catheter inserted. This consists of a thin, flexible tube or catheter placed inside the aorta, the artery that takes blood from the heart to the rest of the body. The balloon on the end of the catheter inflates and deflates with the rhythm of the heart, helping the heart pump blood to the body. The AIBP is indicated when hemodynamic support is required in high-risk patients awaiting CABG or coronary artery bypass grafting. By 15:45, the cardiovascular surgeon was present in the room to look over the films and activate the open heart team. The findings they found in the cath lab to call for the cardiovascular surgeon were 100% occlusion of the left circumflex artery, 100% occlusion of the segments of his left anterior descending artery, 50 to 60% occlusion of his right coronary artery, and then mild left ventricular systolic dysfunction and antilateral wall abnormality with 3 to 4 plus mitral valve regurgitation. Patient had a triple bypass open heart procedure and was hospitalized for 16 days. The door to IBP insertion time was 71 minutes, which I thought was pretty good. I also went ahead and shared with you the ins and outs of the IBP. You can see there it says the IBP rapidly shuttles helium gas in and out of the balloon, which is located in the descending aorta. The balloon is inflated at the onset of cardiac systole and deflated at the onset of systole. I thought that was interesting. I thought they wanted to know about that. And then I just wanted to give them a little bit because it showed all the different arteries that were involved with this gentleman. So typically we give you a really good STEMI report, but I hardly ever tell you about the ones that go on to open hearts. So I thought maybe they should know that. Door to balloon, you will see where we dropped off a little bit in June, 83%. I know that Angie Nolting, who I work with in over across the street, POB, who does the numbers for me, says September is not looking all that great either, but more to come. I'll get those for you. So we're ending up at 98%, which is still pretty good for our door to balloon times right now. And again, I thank you for all you do. Thanks. I know I've talked really fast.
Yeah, you're about to slow down. One of my presenters still isn't here yet. So. All right, so we're going to move on to the trauma report with Jackie Martin.
Funny, he tells me slow down. I'm only doing one case today, but it's a doozy. It's a doozy. It ranks right up there with last night's case. Well, I'll just have to hold it. Okay, so 911 call came in at 14:09. So it's a nice, beautiful, sunny afternoon. If I remember right, I think this was back in August. Don't hold me to that. Dispatch comes in at 14:09. Notice a pattern here. En route at 14:09, on scene at 14:09, departed at 14:09. I said, hey, I think your times are wrong. Medic said, nope. The other truck was right behind it when it happened. So they get here at Union at 14:21. So 0 minutes, 911 to arrival because they watched it happen. On scene time, they were there. And so from the call to getting to us was a whopping 12 minutes. So the Indy crew was over here and behind the motorcycle when it crashed. So right time, right place, bad outcome. There we go. So it's a 30-year-old male. He's in a motorcycle crash. It was reported as excessive speed. Rumors have it 125 plus. Motorcycle would have been a crotch rocket. So it wasn't, I'm thinking a big bike when they start telling me about this. I'm thinking it's like a Harley or something, and it's not, it's crotch rocket. There was no secondary vehicle. There was no impact object. This was pure velocity and force. And you'll understand why I brought that out here in just a second. The medics are probably going, yep, because I think everybody's heard about this run. So the Indy crew was already on scene. So they put bilateral tourniquets on his arms. His right arm went on at 1350. His left went on at 1405. He was alert and oriented ×4. He reported that his motorcycle just went out from underneath of him. He doesn't know if he hit anything. He did have a helmet on. He did not have a loss of consciousness. He was maintaining his own airway and no other injuries noted, but the ones I'm about to tell you about. So they put him on a monitor with defib pads. They put an IO in the right tibia with lidocaine prior to the normal saline, put him in a pressure bag. His vitals are in really good shape. This is a 30-year-old young man. He's 100, and he just flipped over a motorcycle going 125 mile an hour. He's 118 over 72. His heart rate's 126. So he's a little tacky. Well, I probably would be too. His respirations were 20. They couldn't get his sats. You'll figure out why here in a minute. His last got was 15. They gave him 100 micrograms of fentanyl. They did call a flight crew. The flight crew had a 19-minute ETA. So the decision was made to go ahead and bring him into us because they were literally just 12 minutes away. He remained conscious and alert. He was able to answer all of his questions. He was complaining that should be pain to arms and being excessively thirsty. I'm not sure where that one came in. Second IO was placed in the left tibia. Antibiotics were given on scene. They gave him a second dose of fentanyl and put him on a non-rebreather at 10 liters. He had a bilateral arm amputation. He didn't hit anything, nothing. He was going 125 miles an hour, we think. All we know is excessive speeds on a crotch rocket that he lost control of, and he was a 400-pound man. So between his weight and the velocity from the speed, it literally ripped his arms off. Both of his arms were irrigated and wrapped in trauma dressings and Curlex. His lungs were clear. Trauma protocol was followed to the T. She did a phenomenal job on this case. He was covered in a blanket to keep warm. She even charted that. The IRM was called. Trauma team was requested. She told us bilateral arm amputations, and we're all going, did she say both? I mean, like, we're looking around going, did she say bilateral arms? Both arms were found. They were packaged appropriately. They were transported with the patient. They were put in bags. The bags were then placed in ice. And then when we got here, Dr. Dibus repackaged them so we could try and preserve them. He gets to our ER at about 1424. It's a level 1 activation. It is all hands on deck. It became pure chaos in that trauma room. He did have tourniquets noted. He was 391 pounds. He was a very big, very tall, very thick boy. He was in excruciating pain. We put a central line in his right femur, took his spine board out, and we're prepping him for air transport. Now, I'm not sure how familiar you are with the two different aircrafts, but one service is much larger. The craft itself is much larger. We had the smaller craft. That's who was on the rotation when he got called. We did intubate him before we shipped him out. We wanted to protect that airway, and we knew he was going to go to surgery. He became hypotensive, but he recovered pretty quickly with some fluids. He dropped down into the hundreds. We put another central line in. We put an ART line in. We gave him 2 units in the ER, and then we sent an additional 2 units with the flight crew, and he was bleeding, but not massive. If you remember, amputations don't bleed a ton because the body tamponades the vessels off. He got tetanus and ANSEF, plus the medic had given him an antibiotic. Chest x-ray said the tubes were good. They did suspect some blood loss on scene, which makes sense. And trauma surgeon notes that they thought there was probably about a 4-unit blood loss based on his presentation to us. He was airlifted to IU Methodist. It was tricky. They had to really get creative to get him in the craft, but they did it. So at IU, for what's going on, he's pretty stable. He's 114/60. His heart rate's now 142. So his body's doing all that shock stuff. 100% on event. He has a posterior scalp contusion. He has a very small subarachnoid bleed that we found later because it really wasn't his priority diagnosis at the time. He has an acute fracture of his C5. He has a fracture of the C7. And of course, both of the arms are traumatically amputated. The left arm, I think, had a little bit more left of it, like it was down more mid. The right arm, I think, is the one that was up closer to his shoulder. And then incidentally, we find out that he's got some lower lobe atelectasis. So he goes to OR at IU that same day at 1917. So what, 2, 3, 4, 5, 6, 7, 5 hours later? At 6:32, Plastics notes that they're going to attempt to replant, but it was not successful. So they did try to put 1, if not 2 arms back on. I don't remember. I think it was just 1, and it was not successful. It was pretty chewed, not to be gross, but trauma surgeon comes out and said that's the first he'd seen in all his career, and it was the senior trauma surgeon. He said it looked like an IED had exploded. About 9:15, post-op note says he has significant contamination because remember, he scooted along the road. That's what pulled him off. Significant traction injury to the nerves at different levels. About 10 o'clock, neuro says to switch him to an Aspen collar. So we get him out of the hard collar and put him in an Aspen collar and monitor him. Day 2, his parents show up from out of state. I kind of get the impression that the parents are divorced, but nobody really says, but they're both there. They're very supportive. They do an MRI on him on day 2. They put an IJ in place now because it's 24 hours, so it's time to start getting those IOs out. Day 3, he's still intubated. They extubate him that night. He goes back to OR for some I&D damage control. Day 4, he says he will agree. So at this point, he's a 30-year-old man that can no longer care for himself. He's independent. He lived here. His parents lived elsewhere. So he's agreeable to physical therapy. Social worker says that he has really good support. Wherever mom works, she's transferring to Indy. I think at some point, I saw maybe to Lily. Day 5, he gets a little tachypneic overnight, but they test him for PE and he's negative. They do a wound vac to his arms. He goes back to the OR the next day. So this is now surgery number 3 for some more cleanup. Day 6, he goes back as planned. Day 7, he starts having phantom limb pain. So now he's got that going on top of the whole psychological issue. Wound vac keeps going. They start doing some therapy. And, I didn't really think about this until I started reading his chart, but they have to teach him to sit and stand. And if you stop and think about it, you use your arms for balance when you sit and stand. They had to teach him to sit back down from standing and how to walk because he had to learn to rebalance. He was a big boy. Day 8, he reported feeling a little overwhelmed. They start talking about prosthetics. That surprised me that came in that fast. He starts asking about other options. I'm not sure what other options he thinks he has. They worked with him to use voice commands on his phone, and they gave him a special adaptive device. How he gets it in and out, I don't know. They didn't go into details. And therapy notes that at this point, he's really struggling to cope. I don't know if I'd have made it to day 8 or not. He did tell the trauma nurse, he said, you can just kill me now because I can't do this. And here, he told us that. On day 9, his pain got worse at night. That makes sense. His body's trying to do its healing stuff. He is eating well, but if you think about it, they just note that he's eating well. I'm sure mom or somebody's feeding him. They have to. He's transferred out of ICU to a medical floor. On day 10, he goes back to OR for a 4th time. Now they're going to work on the cervical fractures. Day 11, they note he's stable. They think he's going to go back in a couple of weeks for some skin grafts, but they're talking about discharge and maybe bringing him back later. Day 12, he's still doing therapy. He still has his neck brace on. He doesn't do real well in an upright position, but I don't know if that's from the cervical surgery or if he's given up. I don't really know what's going on here. Nutritional evaluation because he's not eating right. So trauma patients have to have high calories. They have to have good nutrition because that's how your body heals. Day 13, he's got some unexplained leukocytosis. Now he's positive for PE. So it's probably brewing before. They put him out on a progressive care unit. On day 14, they note that physically he's healing appropriately. Day 15, they say he's doing well and he's finally eating a little bit. Day 16, he's stable. He keeps doing his therapies. 18, the phantom limb pain gets a little worse. Now he's got decreased range of motion in his shoulders. And so now he can't move his shoulders to keep his balance. But they do say he's got excellent rehab potential, but I mean, you're talking years of rehab. Day 19, they start talking about going home. They go ahead and take him back to surgery a 5th time to do the skin grafts. In day 20, he's still doing therapy. He loses his balance, but he wants to work on going home. He is working on going home. But they talk about going home versus rehab, like long-term rehab. So on September 21st, this patient was discharged from IU Methodist to the IU rehab facility after a 26 hospital day stay. So this medic is about 5'0". She did a phenomenal job. She jumped on it, acted on it, did everything she was supposed to do. I have comments down here, but honestly, I cannot think of anything she could have done any better. I think it was just outstanding. We used to kind of joke that we didn't get a lot of trauma around here, but I can't say that anymore. So this was a big one. We'd had a couple big ones before that. Last night we had a big one. So kudos to you guys. Remember your trauma training because you just never know when you're going to need it.
Thank you very much, Jackie. Guys, I'm going to have to switch. I'm going to move first. Jennifer's not here, so I'm going to move to Angela. Yeah. So Angela Lucas is going to do pediatric patients for us, and then we'll go back to Jennifer when she gets here. So everyone, this is Angela Lucas. You're on. You're still on. You're good.
Okay.
And then
Perfect. Thank you. Okay. So I packed a lot of stuff into these slides because I couldn't decide where I wanted to go with this. Well, I won't, but I have tons of stuff on here. So some of these slides I'll go through in more detail. Other ones I'll just kind of skip through. And if you want more of this information at the end, or feel free to take screenshots if that's easier for you, or you can get my email because like I said, I did pack a lot of stuff into this. So you go, obviously when you're in EMS, you encounter a variety of emergency situations that require immediate intervention. In the US, injury is a leading cause of death and disability in children. Falls in motor vehicles follow closely behind. And I did find one report, this was actually from an ambulatory setting in Indianapolis. It was found that the EMS responded to respiratory distress calls, psych and behavioral emergencies, and seizures the most often, with supplemental O2 and albuterol the most common interventions. And like I said, that was responding to a ambulatory setting. So like I said, I really had trouble trying to distill this down and figure out where I wanted to go with this. So I kind of went all over the place. But the key to a PEDS assessment is really to identify and manage your immediate threats and look at if your patient is sick versus not sick. And we'll get to that in a moment. We're going to look at the pediatric assessment triangle here in just a moment. Pediatric patients often show vague soft signs and they deteriorate quickly. So you have to really keep your eyes on them. Also remember that they're not little adults. There's a lot of anatomical differences, and I'm going to discuss some of those in more detail, and probably more detail than you want to know. So I'll just, some of those slides, like I said, are pretty heavy and dense, so I'll just kind of skim through some of those. So an easy way to kind of assess what's going on quickly, it's like a quick and dirty assessment, is your pediatric assessment triangle. Using that, you can look at appearance, breathing, and circulation. You immediately can get a sense of, is this patient sick or not sick? It's kind of a, from the doorway, I say, I mean, in your case, wherever you're going to be looking, a tool to look at your patient. So you're identifying the problem at that point and looking at the urgency needed for treatment. So the pediatric triangle consists of appearance, breathing, and circulation. So you're going to assess all those things. Like I said, just quickly, you can look from the door. For appearance, are they interacting? What's their level of consciousness? How do they look neurologically? The breathing, you can tell a lot just from looking at a distance. Do they have increased work of breathing? Can you hear them breathing? Are they like in a tripod position? Are they leaning over trying to get their breath? Do you see nasal flaring? Do you see retractions? Not that you can always see the retractions, but some of these other things, obviously you can see from a distance. And looking at the circulation, the skin color, are they mottled? Are they flushed? Do they have discoloration that's something that's not normal? So here's just another quick look at the pediatric assessment triangle. I actually got this from, I think that's from the New York EMS that I found this online. So it's just like a reiteration of what I was saying, looking at the appearance, the breathing, the circulation, and it's something that you're doing and you're going back and forth and back and forth. So you're looking, you're intervening, you're assessing, you're intervening, assessing. It's like a circular type of assessment that you can just keep using over and over. And then you can get into more specifics as you do your assessment after you do this quick look. At the bottom, you will note there are some normal vital signs, and I have another slide with that too. And I will reiterate this again. You cannot memorize everything, obviously, when taking care of a pediatric patient. There are a lot of really great apps that you can use and cards, other things that you can use to assess pediatrics when you're out in the field. So don't try to memorize everything. There are some numbers that we should think about that tell you a lot more about your kiddos if they're in distress. And we'll talk about that again in just a moment. But as I said, this is just going into a bit more detail in the pediatric assessment triangle. And you can see on this other one, the appearance, work of breathing, circulation, some of the things you're looking at that we already discussed. Skin color, the breathing, are they, their positioning, stridor, grunting, wheezing, and the appearance, like I said, are they engaged? Are they making eye contact? Are they age appropriate? All those kind of things. So the pediatric assessment triangle is kind of like a first, like I said, quick and dirty look. You can also use this OPQRST history and the sample history. And I know sometimes, you know, time is of the essence and you can't always get into this much detail, but if you can, these are just some other suggestions of assessment tools that you can use: the sample, the signs and symptoms, allergies, medications, past history, last oral intake, events leading to injury, and you can see the OPQRST on this site as well. You can use checklists, reference charts, and this is another sign, another one with the vital signs. One of the things, though, that you do want to keep in mind is that the minimum blood pressure for a child for any age is like the low tolerance level that you want is like 70 plus 2 times the age in years. So that's just a good tool to keep in mind to think, okay, that blood pressure, we don't want it to get any lower than that. That's the minimum that we want. I also said don't try to memorize specific vital signs because there's really great resources out there. There's phone apps like PDStat. You have a Harriet Lane handbook, American Heart Association, NRP, and I know sometimes you can't pull out your phone, but those are things you could also keep on the back of your badge or somewhere else just to have accessible and easy to use. A lot of those also have the dosages that you need for different medications for pediatric patients. I think one of the things really that, because you know, airway and breathing is such an important thing for pediatric patients, that the respiratory rate, the normals, that's one of the things that I think probably is the most important to keep in mind. So the older you get, of course, the lower the respiratory rate can be considered quote unquote normal. But infants can breathe up to 60 to 70 times a minute and still be considered normal. It's really more about the way that they're breathing than the rate of breathing in any age group. And I know that you all know that too. The Broslow tape, that's another nice tool to have. So you can see red to head on the little image that you have down here in the right-hand corner. That way you can just get another quick measurement. So when you do that, you can get an approximate weight. Of course, if the parents are there, someone who can tell you the weight, that's great. But if not, you also have this as a tool. You can use the weight for the medications and then the length for NGs or ET tubes or other things like that. They give you a suggested size to use for all of those things. And another thing, and I know this is kind of old school and I'm not sure if it's even done anymore, but I know we used to use a lot. The rule of 6 for drug calculations, you just take the weight and multiply by 6. It's the weight in kilos. And then you add that to the number of, that number of milligrams to 100 cc's of solutions. And then that delivers 1 mic per kilo per minute. I know that we used to do that a lot with dopamine and dobutamine and those things. If we had a really critical patient, we need to quickly calculate the drug dosing. So we did the pediatric assessment triangle for like an initial quick and dirty look at what's going on. Then we can move on to like the ABCDE. And I'm sure you've all heard this and it's probably a reiteration of things that you already do and know, but I don't think it ever hurts to kind of go through these things again. excuse me. So the ABCDE is airway, breathing, circulation, disability, and exposure. The airway and breathing, I'm going to focus on a lot more because, you know, that's one of the things that I think that you probably see a lot. And obviously, you know, in a hospital setting, there's a lot of airway breathing issues that you see out, of course, in the field. You see the trauma and other things like that, but, you know, you still always have to follow your ABCs. So these are just some of the, some tips here for the ABCDEs: look, feel, listen, measure, and do. The respiratory rate, you can see 12 to 20 is what they're saying for a minimum. There's your target O2 sats, although I think now they say more of 94 to 99% instead of 98. That's a minimal issue though. Under the disability, I just want to point out the blood glucose level. Don't ever forget glucose, and that is really important in kids, infants, and children. They use up their glucose stores really, really quickly, and getting hypoglycemic on top of everything else is not something that you want to have to deal with. And it really does make a huge impact on everything else, as does temperature control. And I think that looks like what Jennifer is going to be talking about in her presentation. So pediatric red flags. Respiratory rate of over 60. Obviously, if they're breathing that fast, how long are they going to breathe that fast until they don't, right? I think we've all kind of heard that expression before. Significant hemorrhage, respiratory distress and respiratory failure, significant trauma, nasal flaring, again, because that all relates back to the respiratory airway breathing issue, alteration in mentation, cyanosis. I don't know how they ended up so far down my slide. Fever or global rash, modeling, heart rate over 80. And we'll kind of touch on that again in just a bit. Pallor, heart rate less than 60 for obvious reasons, because that's when you need to start your compressions typically in your CPR sequence. Uncorrected noisy respirations and seizures. And most of those I think are pretty self-explanatory. So airway and breathing is obviously your primary assessment. You want to look for upper versus lower airway. If you hear stridor, you have to think that's an upper airway problem. Racemic epi is typically what's used in that scenario. You can also get them out in the cold air. If anybody's had kids with croup, you know, if you get them out into a cold environment, a lot of times that helps. I said it's like the, we used to call it the elevator treatment at, when I worked in the hospital setting, that you get somebody into the elevator and transfer them and they're magically restored and they didn't even need to be in the hospital in the first place. Kind of like getting a croup baby out in cold air. Also humidified O2. If you hear wheezing, it's probably a lower airway issue. You're going to give albuterol, duonebs, consider IM epi, and obviously O2 in high concentration, just like you do for any kind of respiratory issue when you're not sure what's going on. Non-rebreather is never going to be harmful to them. So their hearts take up a lot of space in the chest, so they don't have as much pulmonary reserve. It's harder for them to increase their lung volume because of the space that's already being taken up by that heart in there. The abdominal cavity is really small, so the organs are compressed. This leads to a negative compensatory mechanism of respiration. So they rely really heavily on their respiratory rate because they can't increase the depth because of the size of that chest wall. Capnography, I'm sure you use this a lot out in the field. It's especially helpful with CPR. As you all know, the CO2 drops quickly at the beginning of arrest and then will return to near normal with ROSC. And some of the things I was looking at this was amazing to see how quickly that CO2 level can come back with really good CPR. End-tidal CO2s have been predictive of cardiac output and coronary perfusion pressure. It's obviously also helpful to notice a dislodged ET tube. The cricoid cartilage is the narrowest part of an airway in the infant. So shoulder roll, spell check, R-O-L-L, an oral airway, but of course the oral airway is only going to be in an unconscious patient, and a nasal airway might be used if you need that as well. Nasal suctioning, I had to throw that in at the end because I was thinking about that. Like I said, I was looking over these slides obsessively. So they are obligate nose breathers up to a certain stage. So make sure that you suction their nose. Sometimes that's all it takes is a really good suctioning of the nose to make sure to get their airway working more effectively. The number one cause of death in children is hypoxia. You don't necessarily need to intubate everyone out in the field, and I'm sure that you all are aware of this. Bag masking is okay, and a lot of times preferable, especially if someone isn't comfortable with intubation or you don't have the right tools or there's just no time. If you get a good technique, bag mask valve has been shown to be just as effective. Moans is just a little mnemonic to help think about how well you're going to get a seal on your bag mask. Stiff lungs require higher pressure, so adequate volume for peds is much lower. If you have a big bag and you're using those, I actually learned this from one of the EMS last week. They said if you just use 2 fingers instead of using your whole hand, you're more likely to give a lower volume, and you're not going to hurt the lungs as much or cause barotrauma. You're not as likely to cause it if you're using that 2-finger method. Also, bronchospasm, asthma, those kind of things make ventilation more difficult. So those are things to keep in mind. Breathing, it can be irregular or abdominal breathing in kids. So you need to look at for at least 30 seconds. One thing to keep in mind too is that cessation of breathing for over 20 seconds in an infant is considered apnea. So you need to intervene immediately. Pulse ox, I'm sure that's used a lot too. You want to look at the trend really more than just one specific number. You also have to keep in mind that perfusion is going to impact how well that pulse ox is going to give you a tracing. If you want it to be over 94% on room air, if not, you're going to provide supplemental O2. If it's below 90 on a non-rebreather, you want to provide assisted ventilation. And I said here at the end, treat the patient, not the monitor, which I know you're all really great at doing that. But I think with children, it's really much more stressful, and you want to fix them, but still just keep in mind you're treating the patient and not the monitor. So this is just a lot, and I'm just going to really glide through this one. They can only have minimal swelling before they get compromised. That's one thing to keep in mind with these kiddos. Think about the size of their trachea, and you realize why they can't take much swelling before they really get into trouble. The tongue is larger in relation to the amount of free space in the oropharynx. You can actually aspirate much more easily on either the right or left mainstem in kiddos because of the way that their mainstem bronchi is angled when they're children. I already talked about this. They are obligate nose breathers. That's the direct path for airflow for them. So really keep an eye on the nose, and like I said, suction that out. And sometimes it's a matter that's going to help immensely. Circulation, the pediatric heart has difficulty increasing the stroke volume. They can only increase the heart rate and attempt to increase stroke volume just because of the mechanics at the heart as children. They have low compliance in relation to the volume, and they can't compensate well by increasing their stroke volume. So another thing to think about is when they're bradycardic, it should be assumed that the cardiac output has been drastically reduced. And I think most people know this, is that bradycardia is usually due to hypoxia. So if you can prevent hypoxia or fix the hypoxia, you're going to have a lot more success in dealing with the circulatory part, especially when the bradycardia is involved. So always remember your ABCs first. I don't know why I felt like I had to put that on there, but I did at some point at 20 slides in here. I think it's so common sense that why do I even have to say it? So if you do get into situations where your patient is shocky, you give fluid boluses of 10 to 20 cc's per kilo of isotonic normosaline LR for shock. If you are concerned that there's something cardiac going on, then you do give smaller boluses. It's 5 to 10 per kilo in those scenarios. Just remember too, your circulating blood volume in a peds patient is only 70 to 80 cc's per kilo. So you can imagine losing not a lot of blood can cause pretty significant issues in kiddos. They can also be normotensive for a significant amount of time. Kids are extremely resilient. They have good hearts. They have good lungs. You have to remember, they don't have all that. They haven't been eating all the donuts and not exercising and watching Netflix for 5 hours. Not that I've ever done that, but I've heard that people do that. But you have to remember that they can compensate a lot more easily than adults. So they can be normotensive for a long period of time. So that's something to keep in mind as well. Elevated heart rate. elevate heart rate and SVR to compensate. So watch for tachycardia too, that's not improved after initial assessment and giving fluids. Those kiddos probably need more fluids. And like I said, they can't be normotensive, and their heart rate is going to elevate to try to compensate for what's going on. And if they remain elevated, keep pushing fluids because they probably need more fluids than you thought immediately. Pulse evaluation, brachial, femoral, carotid. In an infant, you can also feel the cord if it's a baby, or the fontanelle. You can always also listen to the apical. Cap refill, you look at the core in kids closer to the knee or forearm, and you know that you want the cap refill to be to 2 to 3 seconds. You can see a picture here of a kiddo on the right with some pretty significant cap refill issues, it looks like, going on there. So I just put these up because I want to remind myself to talk about tachycardia. So if it's tachycardia, you're going to obviously look at the rate. If it's a high rate with no P waves, you're going to think it could be an SVT. You want to try ice and vagal maneuvers before you would give medications. And I know that these aren't things that you maybe see that typically, but I just wanted to kind of review them for a minute. And you can see on the left-hand side that I do have the PALS, American Heart Association, algorithm for pediatric tachycardia. Also remember that babies and kiddos will get tachycardic with anxiety, when they're shocky, with other things, but this, I just wanted to specifically talk about, you know, the SVT that you might see with a high rate that doesn't have P waves. And SVT, people consider it like over, I think, 180 in kids and over 220 in infants. But it's really, the important thing to really look at is on the EKG, if you have it, is to see if you have a P wave or if you don't have a P wave. And that's going to kind of determine, you're going to have more variability with a sinus tach. And SVT, you're going to have a pretty stable rhythm, no matter how much movement the child has or what else is going on with that kiddo. If they're bradycardia, it's very likely hypoxia. And I know I keep saying this over and over, but it's very, very true. If you can fix the hypoxia, a lot of times you're going to fix that bradycardia. You're going to give high concentration O2, non-rebreather. Obviously, if their rate gets less than 60, that's when compressions come into play. We already talked about the pulse check. The one I put on the right side was just, it's about COVID, and it really has nothing to do with the slide, but I just found it interesting because I thought about how different our world is now and how much the first thing, verify scene safety and don PPE and limit personnel. It's kind of fascinating when I think about now what you guys face when you're out there, because it's so much more complex because of all the COVID and what you have to think about in that regard. Disability, these are just the pediatric trauma score. This tickles was on earlier too on another one of the slides. I think it was in the pediatric assessment triangle. And I know I'm not going to hit disability and exposure as much because I think the airway, breathing, and circulation is really what requires more focus. I mean, obviously, if you have a trauma patient, you're going to focus on the trauma part before you're going to do the ABCs first. Let me just say that. I'm just going to back that up. But if you have a trauma patient, obviously, you're going to be focused on caring for the injured area as well as the airway, breathing, and circulation. AVPU is a nice little reference that you can use for disability. Are they alert? Do they respond to verbal stimuli, painful stimuli? Are they unresponsive? There's also the Glasgow Coma Scale. So here, I said we were talking about hypoglycemia earlier. They have decreased glycogen stores. Then they have increased metabolic rates, so they're going to use more glucose. Stress may make them hypoglycemic. I put oral glucose, but of course, obviously, if they're not conscious or their blood glucose is low and you're concerned about giving oral glucose, you always have the IV option. The bones aren't completely calcified and they're more flexible. Ribs are more horizontal. So these are just things to keep in mind for disability about the way you're approaching care of those patients whenever they might have trauma to the midsection. I like this trauma score so much, I put it on here twice. Head injury is the most common cause of death in pediatric traumas. Falls are the most common mechanism of injury in children. Just keep in mind too, and I know you've probably seen this, when they get scalp lax, it can look like they're bleeding to death. It looks like it's significant. Sometimes it is, sometimes it isn't, but it can cause hemodynamic compromise because you do have a lot of capillaries and that are really close to the surface there. Check for bulging fontanelles in kiddos up to about 18 months because they still have an open fontanelle. Skull fracture should be a concern for possible non-accidental trauma, which I think goes without saying. Cervical spine segments in kids under 8 are hypermobile. Keep that in mind as well. A pulmonary contusion is the most common PEDS injury. They may have no external evidence of that though, so keep that in mind when you're out in the field and there's some kind of trauma that you're going to. You should have an early suspicion for tension pneumo out in the field when you come to a trauma setting. Those are the ones that will need a needle decompression. The rib cage offers less protection of the intra-abdominal organs, weaker muscles, decreased abdominal fat, so they do have less protection. The spleen is the most common area, the most common organ injured, then the liver. If you do see a handlebar injury on kiddos, you should suspect pancreatic injury. If you see a positive seatbelt sign, it's typically predictive of an intra-abdominal injury. So non-accidental trauma, approximately 10% of PEDS patients hospitalized due to trauma. One study that I found, and I have the reference on the last page if you want information on that, found a 6-fold increase in mortality with non-accidental trauma patients compared to accidental trauma. There was a delayed recognition in approximately 20% of those cases. And I think a lot of it is, it's hard for any of us to think that these could be non-accidental trauma. And it's a lot of times in the scenario, if you go into it, it's hard to detect if it's accidental or non-accidental. Head trauma can be vague, vomiting, irritability, delayed development, poor PO feeding. And head trauma is the most common cause of death in non-accidental trauma. Some red flags to look for: patterned bruises, bruising in young non-ambulatory babies, kiddos, bruising in areas other than extremities, symmetric burns, any injury or non-matching history. Exposure, you want to undress them and log roll them. The pediatric body surface to area to volume is 4 times that of an adult. Heat production is only 1.5 times. Heat production is only 1.5 times as high as it is for adults, so they're at a greater risk for hypothermia. And I think that Jen's going to be talking about temperature regulation. Your muscle tone is more immature. They can't effectively induce shivering. They also have, as I already said, smaller amount of adipose, so they don't have a lot of insulation. So you're going to obviously assess for bruising or some type of rash. Do they have an infectious process going on? Could you see purpura or something of that effect? And I just had to put this sad little baby in here because look at she's looking kind of sad down there. I think that's all that I have. I know that was a lot of information and I just kind of did skim through it, but I think that's it. You guys and gals do a great job. We appreciate you.
Thank you very much, Angela. Appreciate that. I'm going to go back now to Jennifer. She is going to come up here and do thermal regulation as soon as I get there. There we go. Jennifer Jager is going to do neonatal thermoregulation for us, and she's brought some toys. So she's going to be coming up here in this corner, and she's got some things to show you guys. Ready to go.
Okay, gotcha. Okay.
Good morning. I'm going to be talking about neonatal thermoregulation for EMS. Thermoregulation is a challenge in the hospital setting, so it's really a challenge in the field. My name's Jennifer Jager. I work in the NICU here at Union, and I've taught paramedic refresher courses in the Wabash Valley several years and several times to the Vigo and the surrounding counties. So why is temperature important? The more a newborn loses, the more heat they lose, the more they're at risk for multiple things. Infection, acidosis is a main thing. When a baby Well, when a baby is cold, they're using more glucose and oxygen. So if a baby's cold, your glucose and oxygen levels are also going to fall with that. These are goal temperatures here. Yes. Okay, will do. So these are some of the consequences. Number one, the risk of dying, morbidity and mortality goes up 12 times when a baby's temperature goes below 36.5. And I'm talking about newborns born in the field, but also we're talking about babies that are a month old up to 28 days. They can't shiver. And if they're sick, if you're going to get them because they're sick, generally they can't flex as well. So they're going to have less ways to conserve heat. Hypoglycemia, so you need to check a sugar. Again, if they're using their oxygen and glucose, they're going to become acidotic. Increased risk of infection. They're going to have respiratory distress. And you have these other issues down the line. So as I said, in the hospital, it's already difficult to prevent them. So what can you do in the field? You want to get them inside your vehicle if you can and turn the heat all the way up. If you think about it, inside the uterus, it's 98.6 degrees. So if you're suddenly born into a 70-degree vehicle, or I can even remember an instance where babies have been born in the snow or just in the grass. So they're going to get cold fast. They're wet, and being delivered into that cold environment is not going to help. NRP recommends that delivery room temperature is 74 to 77. So everybody else is going to get really uncomfortable, but it's important to keep it warm for the baby. First thing is, once the baby's delivered, is to dry the baby. So you're going to wipe as much wetness off the baby as possible, and then get those wet linens away from the baby. You're going to trade out for dry linens. If they void on the blankets, you need to switch those out for dry ones. If they spit up amniotic fluid, you need to switch those out for dry ones. If there's bleeding, you need to switch those out for dry ones. You want to get a hat on the baby as soon as possible. Their head to body surface, you know, that ratio is large. So you conserve heat by getting a hat on the baby. Next thing you want to do is chest to chest with mom in a fetal position. So what we see a lot of times, let's see if I can clip this on so I can hold Mike. Does that sound good? My friend Mike. A lot of times you'll see people want to hold the baby like this, but it's important to get as much surface area to the baby. So on mom's bare chest, and you may need to cut away your clothes, you want to put the baby chest to chest, get the baby tucked up in fetal position, turn their head to the side with their hat on. Sorry, Mike. And then you tuck blankets all around the couplet. So then on mom's chest, the baby can be transferred to the facility like that, all tucked in. And again, no clothes. It needs to be skin to skin, as much surface area touching as possible. If you can sneak an oximeter on their right wrist, you can plug that into your pulse ox, and you're going to get an oxygen level, and you're going to get a heart rate, so that you don't have to keep pulling blankets down to listen with your stethoscope. You can keep the couplet close together to help with your temperature control while you transport to the facility as quickly as possible with the heat blasting. Yeah, definitely want to go fast. So these are all the ways that heat is lost, and it's going to be hard to control in your environment. But inside your vehicle, try to keep the doors shut. Try to limit how many times they're open, maybe gather all the equipment at once. Is it possible to put it in the front seat so that the back doors aren't opened? Every time those doors open, hot air is going to be pulled out. Try to limit movement inside. So if you're rushing around the cart, you're creating drafts. They're going to cause more convection. If there's kind of hard to control this, but we make sure like cold equipment is kept away from the babies. because they can lose heat through radiation and conduction if cold things are near them. So again, the main thing, keep them dry, keep the back of the rig with the heat high, keep the doors shut, try to keep movement to a minimum. Oh, another thing I want to mention, I love these pictures. All deliveries in the field. When you're monitoring their oxygen levels, know that in the uterus, the fetus's oximetry is in the 60s. So as soon as they're born, we don't expect them to be satting 85, 90 and greater. You have about 10 minutes for that. So you want to limit your oxygen use. Oxygen is a very cold gas. And when a baby's breathing it in, it's going to their heart and lungs, which is circulating, and it's gonna cool their core temperature. So just know that SATs in the 80s are fine for about the first 10 minutes of life. So be careful, minimize your use of oxygen delivery to a neonate. Any questions? I would not in the field until, you know, there's probably a reason the baby was born so quickly. Precipitous delivery is pretty stressful to an infant. So the baby probably needs to be assessed before we put anything in its belly. The other experiences I've had where babies are born in the field is because the mother doesn't want to come to the hospital where we can do drug testing. Yeah. Yeah, I would hold off on that, but okay. Skin to skin. Good question. Thank you.
Thank you very much, Jennifer. Thanks to everybody that presented today. Guys, a couple reminders for you all to let you know. If you have the capabilities of using the eBridge app, please use that eBridge app. Please send in those traumas, those STEMIs, those strokes. Hit those buttons, okay? That's really cool. And so, yeah, love the pictures, love the 12 leads being sent in. Okay, if you're having those kind of things, please use that. Also, for the paramedics, if you have not done your RSI training, next Wednesday, Thursday, and Friday, Regional Hospital in the old Health South building, 9 to noon, all 3 days. You'll be taking the written test, and you can do the test out with Zach. I'll be there those 3 days. You make sure you have this done, because if you don't have it done by January 1st, you're not working in the EMS system. It's as simple as that. That's just something that required by our medical directors. Also, I just got an email. Sullivan is doing a paramedic refresher in January next year, in January 2022. If you're interested, I can send you the flyer. Email me, let me know. In addition to that, make sure you email me to tell me or text me that you were on today, so I can get you down on the list as attendees. I'm going to go ahead and close it out now, and I appreciate everybody's presentations, and thanks for joining us today.